Aortic dissection can be very deceptive in clinical practice, but when it comes to the boards, the PANCE will make it very obvious that you're dealing with aortic dissection. You just have to be on the lookout for those appropriate clues. My name is Maruf, and in this video, we're going to go over aortic dissection exactly the way that you need to know it for the boards. Let's dive right into it. In aortic dissection, you have a tear of that innermost layer of the aortic wall, which in turn is going to allow for that middle layer to get split like butter, creating a new false lumen where blood can now get stuck. Arterial tears are an extremely painful process because they have such a rich neuronal layer around them. Just think about the pain that you get when you get your blood drawn, but instead of just a second of that pain, you're going to feel that intense pain constantly as that aorta continues to rip. By the way, this is the same reason why a subarachnoid hemorrhage of the brain is described as that classic thunderclap, worst headache possible. When it comes to aortic dissections, patients will present with a very similar thunderclap pattern, but to their chest pain, where they'll classically describe that chest pain as this acute onset of ripping, sharp, tearing pain that has remained a 10 out of 10 intensity from start to present. Patients will usually say that chest pain also radiates through to the back, which should make sense since that aorta is technically right in the center of the chest and the back. So for the PANCE, that description of a sharp, ripping chest pain that radiates to the back and has remained at maximal intensity should immediately make you think aortic dissection. Now, as that false lumen continues to expand, it'll start to abut into that actual lumen of that aorta, causing an obstruction to the flow of blood to those patients' various organs. Now, this is where the real danger lies, and that list of the organs that can be affected is really expansive. But we're going to stick to the ones that you just need to know for the boards, starting with a PANCE favorite, which is a dissection involving the brachial arteries. Now, the dissection will cause a decreased blood supply to that respective arm, leading to a significantly weaker pulse and weaker blood pressure to that side. The patient might also complain of pain, numbness, or weakness to that arm, which will again suggest a dissection involving that brachial artery. The PANCE really loves this one, even though it's a pretty rare find, but if you see signs of blood pressure differences, then this is an aortic dissection until proven otherwise. Now, sometimes the aortic dissection can propagate proximally towards the heart itself, causing a dissection of that aortic valve tissue. That's going to result in an acute aortic regurgitation, which can significantly worsen that patient's disease. You know your patient has aortic valve dissection if the patient has a new diastolic murmur that suggests an aortic regurgitation. If the dissection propagates into the coronary arteries, then you can essentially develop an acute coronary syndrome, ranging anywhere from unstable angina all the way up to a STEMI, but not due to atherosclerotic disease, instead due to obstruction caused by that false lumen. Now these patients will have ST elevations and troponin patterns just like atherosclerotic patients, so it's easy to get fooled into treating these patients with normal ACS protocols like aspirin and heparin, but it's very important that you don't do that. These patients will rapidly decompensate if you add a blood thinning medication to their already tearing aorta. Instead, identify that underlying aortic dissection pattern and treat the underlying cause. Now, the dissection can even propagate into the pericardial tissue, causing a cardiac tamponade due to hemopericardium. We're going to talk all about cardiac tamponade in a separate video, but in general, if these patients come in and they start to develop shortness of breath, JVD, and hypotension on top of that classic tearing, ripping pain, maximal intensity, then you should recognize that this is not just a simple cardiac tamponade, it's a consequence of the aortic dissection. So you should not treat these guys like you would cardiac tamponade, so no pericardiocentesis here. Instead, treat the underlying aortic dissection. That's going to be the answer. Otherwise, aortic dissection can result in a whole host of diseases depending upon what portion of the aorta gets dissected. Like you can get a stroke, mesenteric ischemia, spinal cord paralysis, acute kidney injury. That list is so expansive, but the PANCE is not going to expect you to muddle through a sea of symptoms to identify an aortic dissection. Instead, they're going to make sure to give you that classic description of that ripping chest pain that is maximal intensity, and it's your job to recognize, hey, this is aortic dissection until proven otherwise. So obviously, not just anyone is going to be walking around and then all of a sudden get an aortic dissection. Instead, what we find is that most patients who get dissections have an underlying degeneration of that tunica media layer, that middle layer of the aorta, which makes it a lot easier for a tear to occur. This is a lot more common in patients who deal with chronic hypertension, where each contraction of that heart is like a powerful wave of pressure against that aortic wall. That chronic process slowly degenerates those internal layers, eventually allowing an aortic dissection to occur. Chronic cocaine use can have a very similar hypertensive effect on those aortic walls due to those sympathomimetic effects. So patients who enjoy the coca on the weekends are a lot more likely to develop a dissection as well. Now, patients with Marfan syndrome and Ehlers-Danlos syndrome inherently have weaker arterial walls due to their underlying connective tissue disorders. So likewise, these patients are at significantly higher risk of developing that aortic dissection. Now, some patients are born with bicuspid aortic valves, which can also increase the risk of an aortic dissection at that site because it's already fairly weak in that region. All these risk factors are good to know for when the PANCE asks non-clinical questions, like which of the following is not a risk factor for aortic dissection. So they are important to know. However, remember, when it comes down to a clinical vignette, if your patient has that classic ripping maximal intensity chest pain, then it doesn't matter if they have these risk factors or not. That patient is experiencing an aortic dissection until proven otherwise. So once you've identified a patient with that classic aortic dissection presentation, the next step is to confirm the diagnosis with a CT aorta. Now, let's make it very clear here. This is not ACS, so the next step is not aspirin. ACS patients would have a dull, exertional chest pain, and definitely not blood thinners. Since this is not a PE, PE would have a sharp chest pain, but it would not be described as maximal intensity. Very important that you make these distinctions early on. Now, in CAT scan, you can confirm the diagnosis of aortic dissection if you can visualize that thin layer of tissue that essentially separates the aorta into a true lumen and a false lumen. Kind of looks like a black and white cookie. This line that cuts into the aorta is called an intimal flap and is the pathognomonic description of an aortic dissection on CAT scan. So be on the lookout for this phrasing and certainly engrave this picture into your mind. Now, obviously, sometimes patients will be too unstable, like they're hypotensive or obtunded, in which case they're not going to be able to go to CAT scan. Some of you might have already known that the CAT scan is known as the tube of death, so just be careful of sending unstable patients to CT. Instead, the next step is to stabilize the patient and then perform a transesophageal echocardiogram on this unstable aortic dissection patient. This is where you go down the esophagus with a thin, flexible probe that has a tiny ultrasound attached at the tip. You're going to position it right next to the heart, and that way you can get much better images than if you were just looking at the heart through the chest wall. Now, the boards don't expect you to read an ultrasound of an aorta, so not much more that you need to dive into in this part. Just know that if your patient is unstable, you should do a TEE instead, not a CT. Once you get your CAT scan results back and you see that pathognomonic intimal flap, you know you're dealing with aortic dissection, and your next step should be to immediately give that patient IV labetalol. Think of each beat of the heart as this high-pressured wave that crashes against the vessel walls. The more beats per minute, the higher the pressure of each wave, and the more damage to the vessel wall. By using labetalol, you get to decrease that heart rate and decrease the blood pressure, making it highly effective in treating patients with aortic dissection, and therefore always the next step. Now, of course, if the CAT scan shows any involvement of the ascending aorta, then this patient also needs emergent surgery, in which case, after the labetalol, you should call your CT surgeon for surgical management of this patient's dissection. This is where a lot of students get all mixed up with the DeBakey and Stanford classifications, but in reality, These diverse classifications were made by CT surgeons to help guide their surgical interventions, not for PA students who are just trying to pass their boards. So you don't need to worry too much about those different criteria. Instead, I would just remember that when you're dealing with a type A for ascending involvement, then you need those patients to also get surgical intervention. So before you wrap up, I want to make sure that you can answer each and every one of these questions with confidence, or go back to the video to clarify any hesitations. Otherwise, be on the lookout for the next video as we continue our chest pain module. I'll see you there.